Imagine a scenario where the sound of your own heartbeat is just so loud.
Right, like deafeningly loud.
Yeah, and it echoes so violently in your skull that it actually physically knocks you off balance. Every single time your pulse thumps, the room just spins.
Which, I mean, that sounds like a bizarre piece of science fiction,
It
right?
totally does, but it is actually a very real structural failure in the hydraulic plumbing of the human inner ear. So today, our mission is to decode a stack of highly detailed surgical protocols covering the complex, almost unbelievable engineering of the human head, neck, and ear.
And it really is a masterclass in structural engineering, just, on a biological scale.
Definitely.
What we are looking at today offers this really rare, unfiltered, behind-the-scenes look at how surgeons actually approach fixing the body's most delicate and critical machinery.
Yeah, we are talking about everything from the exact physics of rebuilding a patient's hearing using bionic materials to the strict mechanical logic behind fixing severe neck anomalies.
It's intense stuff.
It really is. So, okay, let's unpack this. Because I promise you, we are going to explore some incredible biological fixes today, and we're going to dive straight into the deep end of how your anatomy actually functions. We're starting with what might be the most delicate, high-stakes real estate in the entire human body.
Ear.
Exactly, the ear. The surgical protocols we're looking at outline how you literally rebuild the mechanics of hearing using alloplastic or artificial materials.
Right, because when the tiny bones in the middle ear, those are the ossicles, when they get damaged by disease or trauma, surgeons literally have to construct a microscopic bridge to transmit sound to the skin.
Which is mind-blowing.
It is. And the materials they rely on for this, they read like an aerospace manufacturing manifest.
Yeah, they use like solid plastics, right? Polyethylene?
Yeah, polyethylene.
Yeah.
And metals ranging from gold and titanium to stainless steel. They even use specialized ceramics.
Wait, aluminum oxide, right?
Exactly, aluminum oxide.
Just the idea of having gold and titanium inside your ear. And there is one material mentioned in the protocols that really stood out to me, these bone-alive granules.
Oh yeah, the success rates on those are incredible.
The text says they boast a 99% success rate. 99%.
It's almost unheard of in surgery.
Right, but having the right bionic materials is really only half the battle. Getting those materials in there is the actual feat of engineering.
Oh, absolutely. The protocols outline these different surgical keyholes. Basically, how this surgeon physically navigates through the tissue to the problem.
Right, like the endural approach using Lempert's incision. Then there's the postural approach using Wild's incision.
Right, which is made exactly 1 centimeter behind the retroauricular groove.
So just right behind the fold of your ear.
Exactly. And those specific approaches are utilized when the surgeon needs a bit more physical room to maneuver.
But the technique that requires the absolute highest degree of spatial finesse, that would be the transcanal approach.
Using Rosen's incision, yeah. This is where the surgeon goes directly down the ear canal itself.
Directly down the tube. And looking at the constraints for this, it makes perfect sense that it requires a naturally wide canal.
It has to be wide enough to fit the instrument.
Right. And it's also absolutely contraindicated if the patient has otitis externa, which is an infection of the outer ear canal.
Well, yeah, because you'd just be pushing a surface infection deeper into a sterile surgical field. That's a nightmare.
Total nightmare. But analyzing this transcanal approach, I mean, to me, it sounds exactly like trying to build a ship in a bottle.
Oh, that is the perfect analogy.
Right. You are working down this long, narrow, dark tube, trying to assemble microscopic titanium parts with these long, skinny instruments.
It is exactly like building a ship in a bottle.
Yeah.
But in this case, the bottle is lined with highly sensitive cranial nerves.
Oh, wow, yeah.
And the ship you are building has to perfectly conduct acoustic vibrations across a microscopic cap. Right. Which actually brings up a crucial mechanical rule from the surgical guidelines regarding the bionic prosthesis they build.
I think I know what you're going to say.
They explicitly state that a short prosthesis gives a better result.
I saw that, and I really have to push back on the intuition there. I mean, why does a shorter artificial bone yield a better result?
It seems counterintuitive, doesn't it?
Completely. You'd think the goal is just to bridge the gap, regardless of the distance. Like, if the gap is long, you just use a long bridge. Why the strict preference for shorter materials?
Well, if we connect this to the physics of how sound actually works, the preference makes perfect sense. Sound conduction is entirely about vibration.
Okay.
So every single millimeter of material you add to that bionic bridge adds physical mass.
Oh, I see where this is going.
Yeah, a longer prosthesis is heavier, and a heavier object requires significantly more acoustic energy from incoming sound waves just to start vibrating.
That makes total sense. Lighter and tighter.
Exactly. And furthermore, from a pure architectural standpoint, a shorter prosthesis means the surgeon is anchoring the bridge closer to the skate's footplate.
Which is the final doorway to the inner ear, right?
Precisely. And it serves as a much more stable foundation than trying to balance this long, precarious strut all the way across the empty middle ear space.
Wow.
It is all about maximizing vibration while minimizing the structural risk of the whole assembly just, shifting out of alignment.
Okay, so that is how surgeons navigate the ear. But let's shift to why the original biological machinery seizes up in the first place.
Right, the underlying diseases.
Yeah. A major focus in these protocols is a condition called otosclerosis, and this isn't just like generic hearing loss.
No, not at all.
It's a highly localized disorder where the bone in the ear is resorbed and then deposited in a completely disordered way.
Yeah.
It essentially cements the tiny moving parts of the ear in place.
Precisely. The skate's bone literally gets fixed, so it simply cannot vibrate. And this leads to profound conductive hearing loss.
But the mechanism behind the symptoms that patients experience, I mean, it's absolutely fascinating.
It really is. Fascinating and incredibly counterintuitive.
Yeah. The protocols highlight a symptom called paracusis. This is where patients start speaking very softly, often in a really flat, monotonous voice.
Which is the opposite of what you'd expect.
Right. Logically, you would think someone losing their hearing would start shouting because they can't hear themselves. But they whisper.
And the mechanical reason is that they hear their own voice entirely differently.
Because their conductive hearing is cemented shut. So external sounds in the room are muffled, but the sound of their own voice vibrating internally through their skull actually becomes overwhelmingly loud.
It's bothersome to them.
Yes. So to avoid irritating themselves with their own bone-conducted booming voice, they unintentionally drop their volume and flatten their tone.
It is a profound neurological adjustment. Furthermore, this conductive hearing deprivation fundamentally modifies the central auditory pathways in the brain. Well, the brain's auditory centers are suddenly starved for external sound input, so those neural pathways change, which directly leads to tinnitus.
Oh, that constant maddening ringing in the ears.
Exactly. The brain is essentially turning up its internal microphone to compensate for the external silence.
Yeah.
And all it ends up picking up is its own neurological static.
Wow. Just wow. So to fix this cemented machinery, surgeons go in and replace that frozen bone with a tiny artificial piston.
Right.
And the surgical tolerances here are wild. They get highly specific about how this piston is attached. The process called crimping.
Crimping, yes.
They say titanium is the optimal material for crimping because it only covers about 50% of the surface area of the surviving bone it attaches to.
Which is crucial.
Right. But Teflon is heavily criticized. The text specifically warns that Teflon covers 75 to 80% of the area, and it impairs the blood supply to the long process of the incus bone. So essentially, if Teflon wraps around 80% of the bone, it acts like a microscopic tourniquet, right? You're fixing the mechanics, but strangling the host bone.
Exactly. Necrosis is the real enemy here.
Necrosis meaning the tissue dies.
Yes. You can install the most perfectly engineered Teflon piston in the world, and mechanically on day one, it might look flawless.
Right.
But if it wraps too tightly and chokes off those microscopic blood vessels, that living bone is going to die. It will necrotize, crumble away, and an entire bionic bridge will eventually collapse into the middle ear.
Ugh.
You always have to respect the body's original plumbing.
Speaking of precise mechanical tolerances, I have to bring up my absolute favorite benchmark from this entire stack of protocols.
Oh, the flying rule.
Yes. After a patient undergoes this delicate stage surgery, there is a strict, mathematically precise rule for when they are allowed to fly on an airplane.
It's so specific.
It is. The doctor performs a post-op tympanometry test, changing the pressure in the ear to exactly 400 millimeters of water.
Right.
If that tiny titanium piston moves a maximum of 0.5 millimeters and the patient doesn't experience vertigo, they're finally cleared to fly.
Half a millimeter.
Half a millimeter. That microscopic measurement is the literal margin of error between a safe commercial flight and absolute physical agony at 30,000 feet.
It brilliantly highlights just how dramatic barometric pressure changes are on these microstructures.
Yeah.
Now, if the internal damage is far beyond what a tiny 0.5 millimeter piston can bridge, the protocols detail the criteria for cochlear implants, or CIs.
Right, for profound hearing loss.
Yeah.
And the optimal window to perform this is at 12 months of age.
Yes, early intervention is key.
But the structural contraindications are absolute. You cannot do this if there's an active infection, or during pregnancy, or in the case of Michelle's deformity.
Right, Michelle's form.
That is when a patient is born with absolutely no labyrinth in the inner ear. If there's no labyrinth, there's no physical chamber for the implant electrodes to be threaded into.
So a CI is structurally impossible. The internal biological hardware has to be present, at least in some rudimentary form, to interface with the bionic technology.
Makes sense. But here's where it gets really interesting. Circling back to that scenario I mentioned at the very beginning of our deep dive.
The heartbeat vertigo.
Yes. In the section on imaging and CT scans, surgeons are instructed to rule out something called SSCD.
Superior semicircular canal dehiscence.
Right. The symptoms listed are wild. The patient hears their own sounds and experiences sound-induced vertigo, like your own heartbeat or even the sound of your own voice makes you violently dizzy.
Well, what's fascinating here is the internal hydraulic logic of the ear.
Okay, break that down for us.
The inner ear is a closed, fluid-filled hydraulic system. Sound waves push in through one biological window, ripple through the fluid to stimulate the hearing nerves, and then bulge out a second window to safely relieve the pressure.
Right, like a shock absorber.
Exactly. But in SSCD, the bone covering the top balance canal physically thins out or degrades. It creates a pathological third window.
Oh no.
So now, every time your heart thumps or you move your eyes or you speak, that hydraulic pressure wave escapes into the balance canals instead of staying in the hearing canals.
No.
Your brain interprets that misdirected wave of fluid as sudden physical movement.
That is terrifying. Just completely terrifying. Okay, so we've just talked about millimeter precision and microhydraulics in the ear, but as we transition down the eustachian tube and into the throat, it is a completely different kind of engineering challenge.
Well, very much so.
It is way less about delicate reconstruction and more about managing the chronic biological battlefield. We are looking at the throat's gatekeepers, the tonsils and the adenoids.
These are our frontline immune defenders.
Yeah.
But the surgical protocols make it clear that there's a tipping point where these defenders actually become the primary threat.
Right, and historically, getting your tonsils out was almost like a casual rite of passage.
Oh yeah, everybody got ice cream.
Exactly. But today, the criteria for a tonsillectomy are incredibly stringent.
Incredibly strict.
Like,